So chapter 31, we're going to be talking about sleep, mainly focused on insomnia. So half the patients that are in geriatric population are usually say that they do not sleep well. It usually is due to poor habits, or they're doing something throughout their day that is causing them to not sleep well at night. Something like drinking caffeine, or drinking alcohol, or smoking, or doing something in the evening that causes them to not want to sleep. So they don't usually have a constant sleep cycle. They're usually alternating. They'll go to sleep at one time, go to sleep at another time. Whenever you do this, it changes your brain function, so their neurology is kind of probably messed up a little bit more. They're older, so they're deteriorated in that aspect already a little bit anyways. And then daytime napping, that's kind of a big one. Yes, they get rested during the day, but no, they don't sleep at night, so it's going to alter their patterns some more. Things that can also contribute to sleep or lacking of our sleep disorders. So limb movement, like restless leg syndrome, sleep apnea, so they just have trouble breathing at night, and then their circadian rhythm or REM sleep is just all off. So they can have a decreased quality of sleep depending on other things too. Is the patient depending on somebody else? Are they depending on people? Are they depending on people? Depending for or on. They have a decrease in social stimulation, so if they're sheltered and isolated from everybody else, they kind of don't sleep well because they're depressed or they're stressed, or something else is some other factor is playing in here. Nursing homes, these are very big for decreasing sleep because one, if people come in to check on them, it can wake them up, doors opening, having to give medications at specific times, and they don't really alter from schedules on those. Yeah, if you've ever been to a hospital and you've had to stay the night, you know that you don't sleep usually, unless you're given some type of medication that just knocks you out. So there's different types of deep sleep, and most of the older population does not get a restful deep sleep. So your NREM and your REM, for those that don't know, NREM is non-rapid eye movement, REM is your rapid eye movement. So your non-rapid eye movement has 4 stages. It has your stage 1, which is your drowsy stage whenever you're first starting to fall asleep. Your second stage is where most people get most sleep, that's stage 2 of NREM. And then 3 or 4 are usually the deepest sleep. Not everybody gets to these, and that's kind of where the issue is here. REM is your rapid eye movement. This is your deep active sleep state. So you're going to be in very deep sleep, but this can be where your heart rate varies and your breathing rate varies. And I believe this is, yeah, does it say this is where dreams? Book doesn't say if it does dreams or not, but I believe that's where dreams happen. So moving on to the next portion, which is physical and mental health disorders affecting it. So physical and mental health, so starting with the mental health one, dementia. Dementia has symptoms that can cause a patient to become irritated or agitated, disoriented, confused. These symptoms can be increased at night if they're having dementia, and it's called sundowning. So they don't know why it happens, but whenever you have dementia, your symptoms can increase. And it seems to be worse in nursing homes. You can improve this by promoting daytime exercise, and you can also improve it by decreasing the amount of daytime napping. That way they are tired all day, and then they can finally go to sleep at night, get them on a good pattern. Sensory loss, usually if they have vision or hearing loss, mostly the patients can get confused, but things like small amounts of melatonin have been shown to improve their cycles at night and help them get some sleep. Our main focus right now, other things that can happen, other disorders that can keep them, other disorders are arthritis, GERD, nocturia, so having to pee at night, PTSD, anxiety or depression. All of those can contribute to the lack of sleep at night. insomnia is our main focus for this portion of the chapter. There's more, but we're focusing on insomnia today. This is the inability to fall or remain asleep for those that actually want to sleep. So this can lead, so if you do have insomnia, it can lead to anxiety, further anxiety, and restlessness. So the causes usually are due to excess fluid intake. We talked about excess caffeine or alcohol already. Stimulants and medications, so if the patients are getting some type of stimulant throughout the day, it can carry over and not be fully processed through the body, and it can keep on through the night. Smoking has been shown, and physical disorders like heart failure, GERD, and restless leg syndrome also are all things that can cause insomnia and prevent people from sleeping. I'm going to jump over here. So the diagnosis for insomnia is actually really easy because the patient's going to tell you I'm not sleeping, but it's hard as a doctor to tell what is causing it. So you can do a lot of practices. You can do, usually as chiropractors, we would do something more like train healthy habits, try and tell them no daytime napping, rehab or relaxation techniques. So these could be things like meditation or yoga. You could do low doses of melatonin supplemental, pretty healthy, just very low dose, and then you'll want to eventually wean them off because it's a hormone. You want that hormone to be made in the brain, not have to be taking it supplementally. Other common sleep aids are going to be things like your prescription medications, hypnotics, tranquilizers, sedatives. They can all contribute to daytime sleepiness, like we were saying. So if these patients take these and then it doesn't process through the body fast enough, then it can carry over into the nighttime. So things like antidepressants also have a stimulant in them, so it can keep the person buzzed and keep them a little bit upped. If long-term use on medications, they actually can start fading off, so they don't actually work as well anymore either. So it's going to be another factor to play in. Benzodiazepines are one of the most common used. Decongestants tend to be another big one, specifically. I don't remember which was specifically, but and I forgot to say during the diagnosis, if it persists past 6 months, you'll want to do a sleep study. So you can do something called polysomnography, and this is going to be them sleeping all night with all these monitors hooked up to them, and that'll monitor their heart rate, their breathing rate. It'll monitor their whether they're awake or asleep, whether they're moving or not moving. So there's a lot of good stuff in there. So that's chapter 31 from pages 371 to 379, and this was all the way up to insomnia.